All right, we are live. This is Dr. Michael Kaye with the Center for Functional Health, and I have the honor to speak with Dr. Scott Freed tonight. I've been really excited about this. I just finished his last book, The Opioid Crisis, correct? The Opioid Crisis?
Opioid alternative book.
Opioid
Close enough.
Alternative. And it
It's
was to avoid the crisis, thank you. And you know what? It was really fantastic. And both of us treat
Thank
a
you.
lot of people in chronic pain. So, welcome. Thank you very much for taking time out of your busy schedule. I've been really looking forward to this. As you all know, I got lots of questions. So, welcome. It's great to have you tonight.
Michael, it's great to be here with you. And, as we were chatting about before, it's great to be talking with someone so like-minded. So I
Great.
appreciate it.
Super, super, super. So, as we get into this, can you share with people before we get started, like, what is your background? How did you get to here?
Sure. That's a good question. I ask myself many times. Um, my background is basically I am an orthopedic surgeon who developed over the course of time, um, talking to patients and learning from them, the concept that the body really heals itself, and we as surgeons sometimes have the privilege of putting things and lining them up the right way, but the body heals itself. And as I was in practice and I began understanding more and more how my patients felt and how they dealt with operations, and frankly, seeing many of my operations and my colleagues' operations that helped people some, but they didn't get them all better. Or sometimes we didn't, and the operations failed. Um, and began to question that because I see my patients for a long period of time. When you're a resident, you see patients briefly, maybe once after an operation and then never again. Whereas if you start seeing patients 6 months, a year, 2 years after surgery, you start to understand that many people felt a little better afterward, but then go back to still having problems, or sometimes, or even worse afterward. And so I kind of began to see that there was a lot more to medicine than what we can do to people, and more so how we can help people help themselves.
Fantastic. And you also have a company, and it's like a bracing company too, where you get into like almost like medical type of bracing, correct?
Yeah, it's a bracing company. It's a company. Doctor in the House is what happened when I wasn't practicing, when I started on this journey that I talk about. I began to understand that I had to get other things out there to help people heal. My subspecialty is hand and upper extremity surgery. So we see obviously a lot of patients with carpal tunnel. I'm sure you know carpal tunnel
Mhm.
well. And, many of you who are here with us, know carpal tunnel or nerve injury all the way up the arm. And many times I'd have patients who had been operated on once, twice, three times, who then come to see me and ask for options or how to get better. And we began using braces or splints. And over the course of time, I found, hey, I was healing as many, if not more, patients using a brace and some therapy and treatments, such as chiropractic treatment, therapy, lifestyle and activity modifications, as I was with surgery. So more and more, we made these custom braces. And then I'd have patients write to me because after I wrote my first book on carpal tunnel, they would write to me and say, how can I get this brace you talk about? And I'm like, well, you can't. We just make them here. So we'd have people flying in from all over the place just to get my braces. And we'd make them in our therapy unit. And then ultimately, I said, well, maybe we can make something like this so we can get it to people. And hence, Doctor in the House was born. And so the books came out of that. The teaching, Doctor in the House is kind of like our teaching method, our teaching unit, and our unit where we can get the public things they need to help themselves heal.
Gotcha. Gotcha. So, what have you seen in the carpal tunnel world? So, we'll start with the carpal tunnel. What have you seen change over the years? So, if you look at carpal tunnel now compared to 2 decades ago, what has changed?
I'd like to tell you a lot, Michael, but as you know, and we all see, Carpal tunnel is very much thought of as a surgical problem. You have carpal tunnel, operate on it, and you'll be all better. But nobody talks about the fact that 1 in 3 people who have carpal tunnel surgery have recurrent carpal tunnel. They still have ongoing problems. And even more if they go back to the thing that caused it in the first place. If you're beating up your hands, you're using a jackhammer all day,
Mm.
you're on a keyboard over and over again repetitively, um, you the underlying problem with it is tendonitis or inflammation. You calm down the inflammation, it takes pressure off the nerve, and the symptoms calm down. Eventually, the nerve gets scarred and stuck, and then you have a permanent problem or an ongoing problem. But when you decrease the pressure, you decrease the inflammation, patients get better. So rather than we as doctors doing the first approach and just giving patients the easy way, saying, hey, what are you doing to cause this problem? Can we change it? Can we do some other things to make that better? We say, well, we can inject you and then operate on you. And we don't give patients the time in between, and the understanding of what the actual physiology is. We were talking earlier about the fact that you sit down and you talk to your patients. You understand them. You understand their life. I remember a joke a long time ago. This mom takes Susie in to see a pediatrician, and she says she's having these terrible headaches. I can't get rid of them. And Susie's sitting in the corner, banging her head on the wall. And the pediatrician looks at the mom, looks at Susie, says, "Can I talk to her a couple of minutes?" And she goes, "Yeah." So he sits and talks with Susie. Says, "Why do you keep banging your head on the wall?" And she goes, "It feels so good when I stop." And you know,
From
the concept is, so many of the things we do to ourselves hurt us. Runners, I've never been able to get a runner to stop running. But running isn't the best thing for most of us if we
Correct.
don't have that fluid flowing motion in running. So we pound the knee and the knee joint, and we develop wear and tear in there from the pounding on a regular basis, getting ourselves healthy, but basically ruining our knees. We do many things in our daily lives. If we stop and think about it, oh, that's the underlying cause of what our discomfort is. And that became the philosophy, the same with carpal tunnel. You can give people a wrist brace, but not the ones you buy in the store because they cock the wrist back. Cocking the wrist back puts as much pressure on the nerve as bending it down. So a wrist neutral brace is the right brace. But yet, the medical community continues to give the same braces we've used for 100 years, and they're incorrect. Hence, my philosophy, okay, let me make some braces from a doctor's point of view, what the literature says, not what we're just using. Rigid back braces. I mean,
Mhm.
you treat a lot of patients with back pain.
Yep.
I see a lot of patients with back pain, and especially upper back pain and neck pain. But back braces, if they're too rigid, don't allow you to live. But if they are flexible, they can enhance treatment. It enhances chiropractic treatment. It enhances lifestyle and activity modifications. And then it just gives a little support in there when needed. It's a whole different philosophy of bracing and healing. But the real concept is, hey, give people the tools and they can heal themselves most of the time.
Agreed. And we spend a lot of time on the biomechanics, right? So and if you can speak to this, would be great. For our carpal tunnel patients, they come in, even if it's, I got this tingling sensation in my fingers, right? That kind of sensation. My neck is tight, and they're computer folks. Ergonomically, go to that ergonomic mouse that puts their hand in this position as opposed to this position. We
Yep.
found, like, in this upright position, everything stays neutral.
Hmm.
They feel better. They feel better not just here at the carpal tunnel,
Yep.
but also through the upper extremity, even to the cervical spine. So we find that when we can get them out of that forward head posture, when we get them out of the chair, because I'm not a big
Hmm.
fan of the chair, get them on a good ergomat. I often change the shoes throughout the day as
Mhm.
well. Go with a zero drop shoe, no shoe, a little bit of a heel. Make sure that they're moving. Make sure that their computer's smack in front of them. That good
Yeah,
99 position. It does make a difference, especially after surgery as well, right? We find that the outcome of how long does
100%.
something last? It's just so much better when we change the biomechanics.
Absolutely. And there's people who need surgery, you're right. And that becomes that bottom line. Sometimes things have gone far enough where they need an operation. But what do you do after the operation? You can't send them back to getting beat up, and you can't put them in a position where they are. They're keying and they're keying and they're beating on that, or like you said, non-ergonomic posturing. And the other point you're bringing up, Michael, is that, all carpal tunnel isn't carpal tunnel. A lot of
Right.
it isn't. It's the nerve goes all the way up the arm to the neck. This is where the nerve starts. C5-6 comes here, here, and C5-6-7 actually, and down here into these three fingers. And every time you stretch and reach out and away from your body, you're pulling on that nerve from one end to the other. And the scar tissue that forms around the nerve gets stretched, and it makes the problem worse again. So you're right. The ergonomic posture, getting the right way to do things, decreasing the pressure, and making the right diagnosis in the first place. I see so many patients who are diagnosed as having carpal tunnel, but the real problem's up here.
Mhm.
And, all nerve pain, all numbness and tingling is not carpal tunnel.
Right.
And all numbness and tingling is not a disc in the neck. But
Correct.
between the neck and shoulder is your thoracic outlet where all those nerves come out of. And car accidents, side bending whiplash injuries, people who are sitting, like you said, posturing all day long with that hunched shoulder. And, this is where the problem is in many cases. And secondarily down here. So
Right.
operating their carpal tunnel isn't going to get them better, or not
Yeah.
all better. And that's the key.
Yep. And we'll see because I'll use a lot of the old. I'll take you back to your schooling there. Phil Greenman's muscle energy techniques. Was it Greenman that
Yep.
had the muscle energy techniques, right? So a
Yes.
lot of that myofascial unwinding for the neck upper quarter. A lot of my osteopathic colleagues, they say I don't have the time to do it, so they're kind enough to send it our way. It
Yep.
works out well because it
Beautifully.
does
Yeah.
take time to get in there. Look at that upper quarter, see how that upper quarter is functioning in relationship to what's happening with that tingling that's happening here.
Yeah.
So the usual standard for assessing carpal tunnel has been the EMG nerve conduction study. Is there any other new standards to look at carpal tunnel, to look at thoracic outlet?
Absolutely. Yeah. And yes, the EMG does give you information. It tells you how the nerve conducts electricity from point A to point B. And the EMG is helpful in looking at the carpal tunnel. But it's not the most comfortable test you'll have in an
No,
afternoon.
it's not.
I mean,
Been
they're
on the
taking
other side of that.
yeah, it's a little electric shock in here, and
Yeah.
it's not the most fun in the afternoon. Is it necessary? And have I ordered them over the years? Yes. Do we do them? Of course, because it lets us know if the nerve is dying. It lets us know, in my mind, if it's safe not to operate on a patient. But the ultrasound is the thing to me that has made the huge world of difference. Ultrasound, the same as baby ultrasound, but the probe is slightly different, but it's sound waves. But I can look at the carpal tunnel. In fact, we operate under ultrasound without having to make an incision in the carpal tunnel. So if patients do need that scar that's around the nerve, we can push it away just by injecting a little fluid in there and no incision, and we can fix carpal, but we can definitely see the carpal tunnel. And we can also see the brachial plexus or thoracic outlet. And the thing about ultrasound is we can see the inside of the body live. The only better look I get at the inside of the body is when I operate on it. And it's
Mhm.
a lot to ask people to cut them open just so I can see what's going on.
Right.
So, but basically, up in here, the brachial plexus, we know the standard tests, if you bring the arm up in the air and the nerves get compressed up here, it's a brachial plexus problem. It's not a disc herniation. It's
Mhm.
not your carpal tunnel. It's nothing else but this, the thoracic outlet brachial plexus injury. And with ultrasound, we can look at these nerves. And when we bring the arm up in the air, we can see the nerves compress, actually see it happen. And the patient says, "Oh, my hand's numb." That is the beauty of ultrasound and the beauty of the diagnostics. And it's pain free. We've been using it for years. And in fact, the papers we wrote on this, on using ultrasound, it's the best complementary study to most everything we have, and it's the least uncomfortable, and it's easy for the patient, and they have immediate results.
So in looking at the ultrasound compared to the EMG study, do you get a better result with the ultrasound? Is that correct, or is it like, so first line was usually, hey, we're going to send for the EMG. So you're
Mhm.
saying now it's like, hey, it's much easier to just send for the ultrasound. It's a lot less painless. I mean, compared to EMG,
Yeah.
I've been on the other side, right? So,
Yes.
but the confidence level, the specificity level of the ultrasound gives us enough information to decide if you need to go in. Is that correct?
Yes, it's correct. In fact, the ultrasound is equally effective in diagnosing carpal tunnel as EMG with no
Gotcha.
pain. But the the way I use them is, if I have a significant carpal tunnel, if I see significant scarring around those nerves on an ultrasound examination, and I see the nerve compresses severely in different positions, and the patient's showing clinical signs of constant numbness, or the muscles are beginning to change in the hand a little bit, I want an EMG as well, because that tells me how badly the nerve is internally damaged. We can see the scar, but we don't know what that translates to necessarily in electrical change in those patients. In a patient who says, I have numbness and tingling when I overdo it, and we see the scar, we have all the time in the world to try therapy, to try the braces, to do it and watch it. And ultrasound is pure and great. If we suspect the nerve is dying, we want to add the EMG as well.
Gotcha. Okay. Super. That's great. Thank you.
Yeah.
So,
Yeah.
in staying on the same thread, right, we're going to work our way up the arm to like a thoracic outlet syndrome, right? So, we were taught decades ago,
Yeah.
thoracic outlet syndrome, it has that very nerve involvement, but there are cases where it can be an arterial dysfunction, right? So, of the cases of TOS that you see, the thoracic outlet syndrome, is it still primarily all nerve related? I mean, you still see mainly that, or do you see where sometimes, you do
Mhm.
the old Allen's test in the thoracic outlets and that it is arterial related?
Mhm. Yeah. I mean, only 3% of brachial plexus patients, thoracic outlet patients, have a combination of nerve and vascular. And in fact, Adson, who originally described the Adson test,
Mhm.
the elevated arm stress test back in the 50s, described this. But if you really read Adson's paper, he says elevation of the arm causes loss of pulse and numbness in the hand. Okay. So what we came to understand, and in the 50s and 60s, Ruse and Hunter developed the Ruse test and the elevated arm stress test, where you bring the arms up, right, exactly.
Yep.
And if the hands go numb, it's not a disc, it's not carpal tunnel, it's a brachial plexus injury. But you don't need the loss of pulse. And in fact, very few have that. If the artery's involved as well, well, it's probably an indicator of a more significant pathology, and certainly it's an indicator for when I operate on these patients that it's going to be a tougher operation.
Mhm.
But I don't recommend the operation, because 50% of patients who have thoracic outlet surgery, as you know, are as bad as they were 6 months after the operation. So it's not a great it's not predictable, because that scar tissue reforms around the nerves. And we haven't got a way to stop scar tissue from reforming, which hence goes back to the fact that it's better to have patients get better without an operation, because any operation we do, and all the good we can do with it, it still causes new scar tissue. And we can't stop that from happening. We can try and do it as gently as we can. And that's where the ultrasound guided procedures, where we inject and push the scar away gently without the incision, we have less recurrent scarring. And we don't seem to see that recurrent scarring, whereas in the other, we do. So, but as far as vascular goes, if it's there, yeah, it's part of it, but the basic diagnosis is neurogenic thoracic outlet. And then the vascular was misunderstood from early on. Everybody thought it was a vascular problem rather than a nerve problem. But they didn't understand why it was going numb because it was vascular and your total artery was cut
Right.
off. Your hand would turn black and fall off, and it's not going to
Yeah.
do that. Yeah.
I think I've seen like one that was truly vascular. To be honest with you, I mean most of it was just nerve, and or they came in. Somebody said they had TOS with scaling anticus, that kind of stuff.
Yep.
Scaling's really a large role, so we'll see that kind of stuff. So when you talk about the injection into the carpal tunnel, we're going to the median nerve. What are you injecting?
We inject usually Novocaine. Novocaine is used. Sometimes we'll use saline if patients are allergic for some reason, but basically it's just numbing medicine. So basically, you just inject in here and you inject it around the nerve because that scar tissue forms around the nerve. And scar tissue around nerves is normally a very thin cobweb-like tissue that allows nerves to move, as you know, or slide through the tissues. And when patients have an injury, such as a whiplash injury or something on those lines, especially at the plexus, that scar tissue can be torn. It becomes inflamed, and then over the next 6 months to 2 years, it reforms around those nerves. But if the injury is significant enough, or patients try to bull through it, and that gets into what you do after these type injuries. If you're too aggressive, you try to do weights, you try to bull through it, you try to push through pain. That means that's actually more scarring forming, and that scar forms more rigidly. And then when you try to bring the arm up, that scar tissue strangulates the nerve, and that's when you have ongoing permanent problems. So we try to avoid that. We try to be nice and gentle, move things, all the medical treatments that you're talking about, the gentle way of
Right.
healing, if you will. And that's it. And then use modalities, different things that help decrease inflammation and swelling. Some massage works very well. The activator works well. Ultrasound works well. Stim, TENS, these are things that help calm down the inflammation and help nerves heal themselves, which they do.
And we're seeing now like a lot of people using like shockwave therapy, or have you seen
Mhm.
that at all? Have you seen any good results with like shockwave therapy, like the extracorporeal shockwave? Where it
Yeah,
started out they were going to use it originally for like the heel spur kind of deal, and then they moved it to
right.
plantar fascia, and now it's like you can do it for tendonitis and that kind of stuff.
Yeah, I mean, shockwave therapy for muscle ligament type injuries, I think has some place. I mean, what it's doing is almost enhancing formation of scar to replace damaged tissue and do that. The problem with shockwave therapy I have with nerve injury is that it re-tears the scar so that
Mm,
healing scar tissue gets actually more aggravated and then heals more aggressively around those nerves. So I have not found it helpful in that case. I found it more the opposite. I found
gotcha.
that and some of the more aggressive injection therapies can tend to aggravate that scarring. And scar, in the case of nerves, is our enemy, not our friend.
Right.
Otherwise, in the body, everything heals by forming scar, which is beautiful.
Right. Right.
External scar, internal scar. Ligaments tear, they heal by forming scar. You tear your rotator cuff, you hope the scar tissue actually fills in those areas of tear and makes it solid again. And that is the beauty of scar tissue, it was God's beautiful plan.
Mhm.
We all heal by forming scar, and that's
Right.
great. And it just doesn't quite work well for perineural tissue, the scar tissue around nerves.
Gotcha. Gotcha.
Yeah.
So before we move away from the upper extremity, I'd be remiss to not talk about ulnar nerve neuropathy, right? Because we do see that. If you can
Yeah.
talk a little bit about ulnar nerve neuropathy, that would be great.
Sure, medial elbow pain, funny bone nerve, your ulnar nerve down here, going down to these two fingers. I mean, most of us have hit our funny bone at one time or another, and you know what it feels like. You know, it's that
Absolutely.
shocking sensation. But you can get scar around this nerve too, and in the forearm also your radial nerve going down the back of the arm, down here, and they're kind of sister nerves, but they again begin up here and become those nerves going down the same way. Um, the key to treating these is the same as the carpal tunnel. It's the same as the thoracic outlet. You know, gently stretching, moving the nerves, trying to stretch that scar tissue around them without feeling pain. Splints or braces to protect it, to calm it down, keeping it in a position, ulnar nerves especially. When you bend past 90 degrees, if that nerve is really ripped out of the groove, it will pop out and in. And you can actually feel it on patients when they do that. So, not bending past 90 degrees. You want to do push-ups or planks, don't go down past 90 degrees if you have an ulnar nerve problem. It's going to rake that nerve over the condyle there and aggravate it. It becomes little modifications here. A lot of the stuff I'm talking about here, you know, I got tired of hearing myself repeat some of these things. My second book was on, it's called the Carpal Tunnel Help Book. It's on nerve injury, and it's a home exercise therapy program. You know, exercises, stretches, things like that. I wrote it a while ago. But it basically, home therapy, home treatment, enhanced by intermittent visits to us, you know, to oversee it, to help do that. In your case, hands on more so. You know, nobody wants me hands on because I'm going to do things to them, and that's not
Right,
fun.
right, right.
But in doing that, in taking care of the body in a holistic manner. And this is what holistic, alternative, integrative, functional medicine healing is all about. We've called it so many different names. It's
Sure.
the body knows how to heal itself. It knows how to take care of itself. We need to give it the tools to do that. That's where these basic pillars of how to take care of yourself come in, and they're simple. They're simple, as you know, and doing it. And the ulnar nerve is the same thing. Nerves just need to be treated nicely. Thinking of them like you treat a baby. If you do that, you're ahead of the game. You
Yep.
smack a baby around, it's a bad thing for so many reasons. You
Right.
can't, you've got to treat them lovingly and gingerly, and people have the right to treat themselves the same way because they were babies once, as my friend Bernie Siegel says. We were all babies once. You ever doubt yourself, look back at a picture of yourself as a baby. You were lovable. you know
Oh,
we're all lovable, and we sometimes forget that.
right. And sometimes we forget that whole self care, right? To love oneself, right? So I
Yeah.
see that a lot where it especially does fall into moms. So here's a shout out to moms. Moms don't put their oxygen mask on first, and they play so many roles, and it's really hard. And we do see that in the office. But you're right. We have to take the time to take care of ourselves, be gentle with ourselves, give ourselves a little bit of latitude, a little bit of room, right? I think
Yeah.
that's really important, and especially with treatment. Because we'll have people come in and they'll come in from other facilities, and sometimes the exercise is too much, or sometimes the manipulative procedure is too much, and
Mhm.
you need to take a step back and like, hey, you know what? Let's do a few nerve glides, not 42 nerve glides,
Yeah,
right?
exactly. Yeah, yeah.
And,
I
and
mean,
that's really important.
yeah, I mean, I so many times we are taught in this country, the harder you do things, the more aggressively you do things, the better you're going to become. And it's such the opposite in healing and taking
Correct.
care of our bodies. And we're allowed to exercise and enjoy that and do these things. But if the body is in pain, it's telling us something. I mean, one of the chapters in my first book, the chapter title was "No Pain is Dangerous to Your Life and Limb," and for the longest time, we were trying to figure out why is that a good statement, but it doesn't make sense. And then it finally was pointed out to me that no pain, comma, is dangerous to our life and limb. In other words, no pain isn't dangerous. No pain is like good. You're not having pain, but no pain. If you don't respect that pain, it's dangerous. And that's what you're saying. Yeah. I mean, and don't overdo. Don't push yourself through to the point of getting to that pain. If you're exercising, great. You don't have to kill yourself. The literature's out there. You don't have to run marathons to have a healthy heart. You can if you're trained for that and you have that. But if I go out and run a marathon, well, first of all, I'm a lousy runner. But if I go out and run a marathon, yeah, and I'm not trained to do that, that's going to put some taxing on the heart that's not good and the rest of the body. And also when the body is not prepped for that and it's not conditioned for that, as you know, it causes damage.
Yep.
And
Yep. For sure. So, when somebody comes in and we're doing rehab, it's like, they're like, all right, well, I've been told I need to do 3 sets of 10. I'm like, hey, why don't we do a set of 5, see how well you do, we'll reassess, and then we can do another set of 5, right? So I'm still getting 15 reps, but we find that when people start doing like 8, 10, 12 reps, and this is, we're talking about a rehab setting, not an exercise setting, right? A rehab setting is like that 8, 9, 10, 12, we start losing technique. So if we're losing technique, then that repetition has no quality.
Yeah.
Right.
Yeah.
So I want to be able to do rehab where it's like, I don't mind some post-exercise soreness, but I want them to feel good enough so we come back again the next day, or they can do a home exercise program. Because if you're in pain, you're not going to have the motivation to do the movement pattern.
Yeah, and exactly what you're saying, and it was pointed out to me years ago. Practice doesn't make perfect. Perfect practice makes perfect.
Right.
So if you're doing those exercises wrong and you're doing them over and over again, it's not only imperfect practice, but it's doing the wrong things to your body. It's not ergonomic, as you're saying, and it's going to lead you to more pain and more dysfunction. And certainly in the case of nerves, and this is the one thing, if anyone is listening to this, if you get anything out of what Michael and I were talking about here, is it's been standard for so long in treatment communities to strengthen everything. And strengthening in the face of pain is wrong.
It doesn't make
In other words,
sense.
moving
Right.
is correct. Moving within your limits, moving when you feel good is good. But trying to push through pain doesn't work. That no pain, no gain theory is not indicated, especially in nerve injury. Especially in nerve injury.
Correct. It makes no physiological sense, right? So,
Correct.
and again, for the patient, I get where they're coming from. They watch so many different videos on the internet and they're looking for an answer because they're frustrated because the typical presentation, they're going this person and this person, this person, this person. Everyone's got their ideas. Everyone's posturing. No one's talking to one another, right?
Yeah.
Everybody's in their own silo, right? But we want to be able to have a team approach, and we want to be able to take it from a clinical perspective. And strengthening isn't, and either stretching, right? So when most person has a pain, they're like, oh, I have to stretch. I'm like, well, maybe we need to create mobility. And we have a lot of patients who, and again, I've been fortunate, seen a lot of patients over the years. They're like, I guess I should have done those hip mobility exercises. I got to get a hip replacement. I'm like, yeah, the squat was important, right? And that was back then. Now we have to look at it differently, right? So you should have done it. So we can't go backwards, but we can go forwards. So
Yes, exactly.
looking at mobility is great. Stretching what needs to be stretched, strengthening what needs to be strengthened, creating that core, and looking at that cardio. And that's how we build a whole rounded person. But
Yeah,
even when
yeah,
you look at all that, there are these presentations that I deal with and you deal with. What I want to jump on to now, it's like this chronic pain presentation, and it's so hard. We had a young man who had transverse myelitis, and it hasn't been good since then, and it's been a long time. And there are times where the person's doing better. So we are now seeing these, complex regional pain syndromes, the reflex dystrophy syndromes, that kind of stuff. So can we talk about those kind of presentations?
sure. Surely, absolutely. Yeah. I mean, they're tough. They are tough problems because when people are in pain, there is nothing else in their life. Basically, the pain can become insurmountable. And, problems like reflex sympathetic dystrophy or chronic regional pain syndrome, as it's called these days, CRPS, many, many names for these pain syndromes, are very difficult. And many are misunderstood by the medical community as well as the patient community. When I say that, um, you know, RSD, reflex sympathetic dystrophy, is felt to be a problem that is pain where we don't know the source. And we fail sometimes as a medical community because sometimes the source is readily available. Um, Especially, when you have a patient who has been fine and then all of a sudden they dive deep and they have this pain syndrome. Nothing seems to be working for it, and they're just getting worse and worse. But we don't look deep enough to say, is there an underlying cause of this in the first place? And, again, as an upper extremity specialist, and the same thing with the lower extremities, so the brachial plexus, and there's a, lumbar plexus as well. It's the same concept. But the nerves that come into the extremity, into the arm, through the brachial plexus carry those sympathetic nerves. Reflex sympathetic dystrophy. The sympathetic nerves are what cause that unrelenting, ongoing discomfort, the color changes in the arm, the ongoing reactivity. And they come in through the brachial plexus. And many patients I see who've been diagnosed as RSD and have been through all kinds of treatments and blocks and things on those lines turn out to be brachial plexus injuries. They had an injury, and when you trace it back, it's, yeah, this is about when it started. And then we look at them and we see, okay, yeah, there's scar around these nerves. There's a problem here. And then it becomes different because if we can find an underlying cause for these problems, then it's not, we don't know when it's going to stop hurting. We don't know when it's going to burn out and burn down. And we can begin to develop treatments, and treatments that are more aimed at that particular individual. And very, very often the symptoms overlap so significantly. In one of my books, my chapters are back to back on brachial plexus injury and reflex sympathetic dystrophy because the symptoms are so
Mhm.
similar because the issues the same. It's these same nerves that are causing that problem. But getting into that, whether a person has pain from RSD, which we don't always know the cause of, and they're told, oh, we don't know what we can do for it. We don't know if it's going to get better or it's never going to get better. I hate when people say that. In other
Mhm.
words, because I've been treating these injuries for 30 years, and I've seen a lot of brachial plexus injury, and I've seen a lot of reflex sympathetic dystrophy. Okay. I can count on one hand the number of patients whose pain level doesn't burn down. And I'm sure you see the same thing. It may not go away completely. You
Right.
may be left with some residual with true RSD. But it generally can reach a point of livability if given the proper environment, the proper understanding, and the proper way to treat that and not beat it up and not continue to poke the bear, if you will,
Mhm.
basically by re-aggravating it. But Michael, we were talking about this before we got on the air, and you know, one of the things that makes me crazy is when patients come in and they say to me, "Well, my doctor told me there's nothing that can be done for me." There's never nothing that can be done. You can have stage 4 metastatic cancer. There's always something that can be done. It may not cure it. You may
Right.
not fix it. You may not even change your lifespan, but you can make that life that you have there better.
Right.
And there are a lot of cases of spontaneous remissions, and the articles are out there all over the place. And I've seen people who've been died, and sometimes people whose scans were a bad scan that day, or tests were tests that, didn't actually, show it, and repeat tests show, oh, you're actually fine.
Yeah.
And you're cured by a repeat test. So, there's always hope. And I think that sometimes we as medical people need to remember that we're talking to people, not patients. We're
Right.
taking care of people. And a lot of the opioid alternative, I probably should have named that book differently, because it's basically giving yourself an alternative. It's, helping people have surgery the easier way, deal with these injuries, these illnesses the easier way. RSD, because if we get in control of our heads, if we just breathe and relax and let our systems calm down, our body gets better. It knows how to heal itself. We just need to give it that, as you talked about, that proper environment, the line it up the right way, mentally as well as the physical. Give it the proper thing. I say every patient who I've ever seen who's over 85 years old who is in good health, I ask the same question. I said, and they're enjoying their life. What's your secret? And they all
Mhm.
tell me the same thing, right? They all say the same thing. You know, I eat reasonably well, I exercise a bit, and I don't take life too seriously. Many of them just have that natural ability to go easy. For me, it was a stretch. I came up in a household where, I'm certainly type A. I became a surgeon, and, but, we all as doctors, we were type A. That's how we got here. But, my dad had 5 heart attacks and bypass surgery by the time he was 52 years old. And the bypass surgery failed miserably. He was a psychologist. And, he would sit on the couch after the surgery and just sit there for 20 minutes every afternoon, and learned later he was using self hypnosis on himself. And he lived 24 years with no blood vessels in his heart. Literally,
Wow.
his cath tapes, his cardiac cath tape showed no blood vessels. And he just opened those vessels, what was left of the collateral vessels, by meditating and putting his mental frame and his sympathetic system in an open state. And he worked 3 jobs up until, shortly before he died. So he was totally productive. You never would have known he was sick, but yet he didn't have a heart that functioned. But he had a heart of gold, but,
Right.
unfortunately not of blood vessels. But I learned early on, and I started meditating and doing that early on. And, I closed my office every day for 30 minutes in the middle of the day, as busy as I was, the only hand surgeon in this town. And, and I closed at midday and I began meditating. And it took me a long time to understand how to do it. I haven't had my first heart attack, and I'm certainly well past my 40th birthday. So, I don't plan on having that,
Right.
because when you begin taking this on yourself and, learn basic techniques and simply just live your life in a good way that's kind to yourself, yeah, life is easier to get better with.
And that's a learned process, though, right? So I mean, even when we have this chronic pain patient, right? And I always talk about, listen, you just didn't get in pain yesterday. We like to look at it in buckets of frequency, intensity, duration. So
Yeah.
is there something I can do to improve one of these buckets? If I'm
Yeah.
getting that, fantastic, right? Because the whole idea is to create resiliency even in the setting of the dysfunction, right?
Yeah.
So that's really
Yes.
important. Like when you experience something, like you said, poke the bear, because I use that same terminology, poke the bear.
Yeah.
When you poke the bear, don't poke the bear 2 and 3 times in a row. Poke the bear once, that's it, right? Whether I'm dealing with an irritable bowel syndrome or whether I'm
Yep.
dealing with a musculoskeletal dysfunction, right? So,
Yes.
you want to put that in line, and there are things that you can do to bring it down. And we talk about meditation, and a lot of these chronic pain people, LDN, they talk about ketamine, the combination of low dose
Mm-hmm.
naltrexone and ketamine. Um, Botox is another one that's
Mm-hmm.
often used. So all of that's important. The stellate ganglion box, we were talking a little bit about that.
Mm-hmm.
All that is wonderful. And this is what I want to talk about, and the meditation portion, right? So if
Yeah.
we don't do something to regulate the sympathetic system, if we don't
Mm-hmm.
get them out of that fight or flight, then we're just pushing that boulder up a hill. And the
Yeah.
and the pushback I get is like, I can't meditate. I tried it, it doesn't work. Well, you know what? You go to one karate class, you're not a black belt overnight, right? So
Exactly.
it's something that you have to really work at. And I'll be honest with you. I mean, I cannot sit quietly yet, but I can do qigong. I love doing qigong.
Well,
So
again, and that's a
I'm
moving
moving,
meditation, right?
right? I'm
Exactly. It's a
moving in
moving meditation.
meditation.
Qigong, Tai Chi,
Yeah,
exactly. They are natural forms of meditation. But the thing, the yeah, I've been putting people into trance, and we've used it in our office and for our surgeries for so many years now. And uh, one thing I've found is almost everyone can relax. And what we don't realize is it's not anything magical or mystical.
right.
You do it every night before you go to sleep, just before you drift off to sleep, that semi awake state. That's the alpha state. We all go there every night. So it's not that we don't know what it feels like, it's just during the day, we are busy and we don't stop, but just stopping and breathing slowly. Yeah, drop your breathing rate. Take a deep breath, hold it for a count of 3, and let it out real slowly. You do that a couple of times, and your body begins to drift toward alpha. And that is all it takes. It's really about breathing and just letting go. We're not going to stop the busyness in our mind.
Right.
But if we decrease those 17 trillion thoughts a second our brain runs through a little bit, we begin to relax a little. And it's not magical or mystical. I think that's the thing people don't understand until they try it once. And then they're like, that's it? That's it? I remember the first time I helped, finally talked my wife into letting me, do some meditation hypnosis with her. And she just laughed and laughed, and then boom, she was in. And, you know, then she was totally relaxed. But as she always says to me, she goes, that's it? That's all there is to it? I can do that. I'm like, I know you can do that. and and that's the thing I hear over and over again. And it's simple. And I'm a simplist. The more complicated we make healing, the worse it gets for everyone involved because we
Sure.
try to add things on and do the next thing. I say start with the easy stuff, start with the simple stuff. Eat reasonably well. You don't have to, like you said in your book. I mean, your book on Boomer's Guide to Chronic Pain. I mean, it's like you don't have to you don't have to stop eating everything in the world. Just a little bit at a time. Change a little bit. You don't have to go out and become a major exercise fiend. Walk a little bit, stand up at your desk for 10 minutes, walk around the room, put your snack jar at the other end of the room so it's not sitting there on your face, and then you have to go get it, so at least you've earned it when you have something. And maybe even consider a healthier snack. I mean, there are little things that you don't have to do all the time. I mean, it doesn't become that. And then you realize, well, I feel differently when I stop doing that, or I don't do that, or when I eat that, I feel better, and then, okay. And then you begin to be in control. And when you're in control, then you make all the decisions. And that's when you're relaxed, you make better decisions. So it kind of all just, goes through itself in the thing. I mean, those are the keys to me to life, to healing, and to happiness in so many different ways. And I've never had anyone say to me, I hate relaxing.
Right. Right. And many are so hooked into the constant barrage of the day. So, for example, I had this young lady. I put her on muscle stim, neck. Have a hot pack around her. It's going to feel wonderful. She already felt loose after we were done. And we have this amazing window where the treatment room is. Beautiful colors outside. It was wonderful. And I said, all right, I'm going to step out of the room right now. And she said, can you grab my phone? I said, what? She goes, can you grab my phone? I said, no. No, if you can't sit here for 15 minutes, look at these amazing colors, then we have another issue in hand more than just your neck, and you have a headache issue.
Yeah,
right?
exactly.
So 15 minutes later, I come back. Her leg is doing that up and down thing, right? Knee. I'm like, how you doing? She's like, I needed my phone. I go, was this for work? No. I go, there's another issue at hand, right? This is an addiction. You can't be without your phone for 50 minutes. That's a problem. We're always trying to get folks to bring it down, right? We remember for decades we didn't have the phone, right?
We're addicted. We're addicted because
it's addictive, period.
The dopamine release we get from every time our phone dings, or we get an email, or we check them. And I mean, I'm as guilty as anyone else. I have my phone, my iPad, and my computer. So I am hooked into my technology, but I consciously have to take a break and walk away from it. And but what happens is we get that same dopamine rush we get from something exhilarating from our phones, because it becomes addictive. And this is as addicting. It is a drug, but it's a technology drug. It's it's a drug that stays with us, and a drug that we're dependent on in a lot of different ways. And you're right, Michael, it's a very hard thing, and we have to wean ourselves down. I will say the younger generation is better at weaning it than those of us who didn't have it from the beginning, because we got hooked in. And I think that the hope is that we can follow their examples in some way and say, when they go and they do something, they'll put it down. And my kids are just basically, it's off, it's out of the way, it's not there, and it's gone. When we be on family vacations, the kids never took their phone out. It was different for us. I'd be hooked on it, and they'd be like, "What's wrong with you?" Yeah. So
it's very, very addictive. Our goal is I always, people who have I say, listen, can we get 60 minutes before bed, no screen time of anything? Well, what do you want me to do? Well, here's an idea. Go meditate, right? Here's an idea. Take a magnesium bath, right? Go journal. Go read a book that you hold on to, right? There's so many things you do to actually create that sleep routine and start turning one down, right? It's definitely a lifestyle thing. And you talked about it in one of your books. I want to read something that you wrote. You wrote here that one of the first things we need to do is change your lifetime beliefs. You've been taught, programmed, and indoctrinated into the fallacy that the medical system doctors take care of you, right? You wrote that, and that's so true. And it's And now we see such a change in medicine, and we briefly touched about, corporate medicine and all that kind of stuff, but we have to change our lifestyle. And
Yeah.
it doesn't
Yeah.
happen overnight. Like you said, just like those little things that we need to do.
Yeah.
Little by little, we can get where we need to get to.
Yeah. And again, exactly as you're saying, the system itself isn't it's geared to do things to you. The
Right.
medical system makes money by giving medical care. That's the only way they make money. That's their job. It's like, if your only tool in your toolbox is a hammer, everything starts to look like a nail. So, when we as doctors, even in our good intention, utilize what we've learned. I mean, I was raised and trained as a surgeon. Most of what I learned was to operate on people to make them better. And yes, we can do great things with operations. But there are so many other ways to get people better. And I should be the last resort of where they're going.
Hmm.
Basically, all the treatments that are available to us and to do that. But the medical system itself wants to do things to you, give you medications, do this, do that. It becomes this. And unfortunately, the system has become so entrenched in big business now that it's the doctors, even when they want. And look, I mean, most of the doctors I've met and I know are good doctors. They really want to do
Hmm.
good things for people and they want to take care of them. But the system is so overwhelmingly there. And then we as consumers, medical patients, go in and say, fix me. And that's what I was talking about there. It's like, I can't fix you. I can guide you to a way to help yourself heal
Right.
yourself. But I can't fix you. I won't fix you. I can't even fix myself. I look at my hair, I mean, you know, it's that we become so dependent on a system and a world that quote takes care of ourselves, but we're the only ones that can take care of ourselves. And truly we're in charge of that. And once we give that up, once we give over that control, we're gone
Hmm.
because we don't know if that person that day was the right one or not the right one. Like I said, there are great doctors, but they don't have time.
No,
And the
they don't.
system has been okay, you can't sleep. Let me give you let me give you something to help you sleep.
Right.
And you're feeling a little down. Let me give you something to help you get through that. And it becomes, well, and patients come in and ask for it.
Sure.
And it takes me a long time to sit with the patient and convince them that they can decrease their discomfort
Right.
by sitting and relaxing or stopping doing something instead of
Right.
I'll take a pill and I'll keep doing what I'm doing. But no, or
Right.
take a pill and lose weight. Okay, we know where that's going. Pills have side effects, okay? And no matter what, every drug, every medication out there has side effects.
Yep.
Aspirin has side effects. We don't have anything out there that doesn't have a cause and effect relationship. So we got
Yep.
to be careful. And just speaking of sleep, just before I forget, you know, that state just before we go to sleep, that state I talked about where we're drifting off, is that open, suggestible hypnotic state. Be careful what you watch at night when you're falling
Hmm.
asleep, especially if you're one of those people who watches the late news,
Whoa.
because your brain is just in such a receptive way to anything that's hit by it. And I stopped watching the news at night after 9/11
Oh yeah.
because I realized how powerful that suggestibility was to me. Watching the planes fly into those buildings and the flames,
Hmm.
I dreamed about it. I had nightmares about it all night because that was the last thing I remembered when I went and drifted off to sleep. And it was literally drilled into my subconscious. And I finally realized that what we expose ourselves to becomes who we are and
Hmm.
becomes what we think. And and we need to be careful of what we allow in. And and that's why you're talking about this quiet time and the peace. Go outside, sit in your backyard, look at the grass, look at the green. Before I walk into my office every day, I get out of my car, I look up in the parking lot, and I look at the sky and the clouds and the sun if it's out and the trees, and I say, wow, that is. And then by the time I'm walking in and I've done my morning meditation, and I try to do my meditation every morning before I start my work, because I'm in a better frame of mind to help me, to help patients to do what I do.
Right.
It's and happier, and I think that if there's one gift we can give people, and we can, wrap this up with, is that, you know, taking care of yourself is a gift,
Yep.
and you owe it to yourself. And if you don't, who knows if you're going to be led in a path that's going to give you a long, happy life, or not. But as we were talking about before we started this show, both of us have had in our heads for a long time, 110 years old.
Yeah.
And, there's no physiologic reason people can't enjoy a happy, healthy life
Right.
at 100 years old. The body doesn't age the way we are led to believe by the system. The body just mellows a little bit, but we can go on doing and feeling great and doing things. And, I I often say to patients, look, you're healthy. I'll look at them on their ultrasound. I'll see their arteries. They say, you got great arteries. You're going to live to be 100. And invariably, many patients say to me, well, I don't want to live that long. And
Yes.
my answer to them is very simply, be careful what you wish for,
Right.
because your expectation is what you manifest.
For
And I
sure.
think that,
For sure.
so I think that you and I, hopefully in your radio show and, your talk show here, and, everything you do is about teaching people to heal themselves. It's what we do. And it's noble. And it may not be the most, let's put it this way, economically beneficial to either of us to have
Right.
chosen the path we did. But in the long run, emotionally, it's a wonderful thing to help people heal themselves. And I think that's what we do, Michael.
For sure. And thank you for those kind words. We
Yeah.
we serve as a conduit to their health, right? And
Yes.
that's the whole idea. And we serve as a conduit to squelch the noise that's out there, because there's so much noise and they don't know what to do. And they read and they watch videos and it's all so overwhelming.
Yeah.
So I think the way we serve them best is to pull them back, share with them clinically what's going on, make these small changes, and just invite them into a new lifestyle, a new way of
Yeah.
thinking, a new syntax, right? A new framework. And if
Yeah.
we can get that, we win, right?
Exactly.
Plain and
Exactly. Yeah.
simple.
Yep.
Well,
Absolutely. 100%.
so thank you very much tonight. This is absolutely fantastic. I do have two other questions to ask you, and I'll let you go because I want to be respectful of your time. So, what role do you feel AI will play? And I've been watching a lot of stuff with ChatGPT and playing around with
Mhm.
that, and I'm looking at these articles coming out with AI in medicine, so I find it interesting. So, what role do you see that coming in? What have you seen on your end? And what book are you reading
As far as AI goes, um, a- AI, I think, has great, great potential for helping in medicine. I think it has great potential for helping us find sources as
now?
patients, to find information and find lots of information and narrow our search to get that. But also, AI is allowing us to develop such wonderful new technologies, different techniques for healing people, different information, sharing of information, sharing of insights into so many of the things we talk about. And, you know, AI is going to create environments for all of us that are healthier for us in a way. We're at the beginning with this, and
Mhm.
it's going to be, I think, gently incorporated there. But I think it's a very exciting addition. But like any technology, as we talked about, you know, take it with a grain of salt right now and use it. It works for you, you know, and so use it at its limits here, but don't look toward technology and AI to fix you. It will
Mhm.
just enhance your lifestyle. It will make it so that none of us will have to drive, because eventually cars will make better decisions based on human decisions that AI has taken over millions and millions of time, and make what a good decision multiple humans would have made and save lives in that. So these are the kind of things I think that make our lives healthier and easier. Better food, better delivery of all kinds of care. And
Excellent.
as far as books go, um,
Because
I
you have so much time.
yeah, yeah. I say I tend to read 5 or 6 books at a time. I happen to be on one most recently, I guess, is Malcolm Gladwell's The Tipping Point,
Yep.
and you know, apropos to exactly what we're talking about, I do think that medicine itself has reached a tipping point where we're giving more and more people control of their lives and the tools to be in control. And I think that's where things like AI and things on these lines do make a difference. So I think we're at a tipping point of very exciting times for everything in our lives to become even better and
Mhm.
happier. And
Mhm.
yes, I'm an eternal optimist, but I have not been disappointed in my many years. So I don't plan on
Excellent.
starting being disappointed in that. Yeah.
And you've penned 3 books. Is there another book that you're going to be writing?
Yeah, it's in process.
Excellent.
It's basically it's on how the second half of our lives can be even better than the first.
Gotcha. Gotcha.
Yeah.
So a better halftime. So that's excellent.
We will talk about that on the air once soon. It's in
I will. I
process.
will. I look forward to that. That'll be
I'm not
wonderful.
at liberty to divulge any more
That's all
information.
right. All good exists something to look forward to. And can you share with everybody how they can get in touch with you and your websites?
Surely, probably the best website to get in touch with us is docinthehouse.com. Docinthehouse.com. That's the general email that would come through, and we get through that, and that gets right to me. And if someone has a question or they're interested in meditation and audios or whatever, happy to help in any way we can, and share in the healing we do together, Michael.
Excellent. Thank you.
Hey,
Thank you so much for your time tonight. I really appreciate it.
thank
All
you,
right,
Michael.
everybody.
Have a
There will
great
be.
night.
Thank you. There will be replays on YouTube, so you'll see that. And you know what? Thank you again. I actually have pages of notes and questions I didn't even get to, so there might be a part 2, folks.
We'll do a
So
part two. We'll actually, maybe we'll even be self-directed in part two.
that'll be great. All right. Thank you, everybody. We'll see you soon.
Thank you all for listening. Have a great night.